One of the best ways to prevent deep vein thrombosis, and really any complication, is to take the central venous catheter out when it's no longer necessary. Now, all of those factors contribute to reducing complications and improving outcomes for patients. How do we prevent thrombosis? Oh, I was behind. There are a variety of ways that we prevent deep vein thrombosis. We want to avoid placement of a central venous catheter with patients that have a history of thrombosis. Think of thrombosis as a contraindication to PICC line placement. We should not place PICC lines in patients with a history of thrombosis. And many people want to say, oh, well, if it's been this long, or if it was lower extremity, or the risk is there. No matter how long it's been, no matter where the deep vein thrombosis occurred, if you put a PICC line in. But there are some things that we can do in order to help to reduce the risk. The use of ultrasound has opened up the opportunity for us to really evaluate veins, to look at the size of the veins, to determine before we put the catheter in that vein is at least 2 times larger than the catheter itself. We want to focus on having a catheter that doesn't take up more than 1/3 of the diameter of the vein. A 4 French catheter should have a vein diameter of at least 4 millimeters or larger. It's very easy, 4 and 4, 5 and 5, 6 and 6, or larger. That meets the 1/3 rule, and that of course is without a tourniquet. And so making sure that our catheter to vein ratio is correct and that the catheter is not larger than 33%. As I mentioned, using peripheral catheters, using single lumen catheters and not using multi-lumen catheters. Encouraging the patient to move, to use their extremities to keep blood flowing well. We don't want that blood to stagnate. We want there to be pumping action that occurs. Encourage good nutrition, healthy weight, avoid smoking. Consider the use of antithrombotic catheters. Unfortunately, the research that we've had with heparin-impregnated catheters and some of those types of preventatives have not been very strong and are not really supported. And even the information on antithrombotic catheters is still very small. But it is developing, and there has been a recent randomized trial that has shown some benefit. For patients that have a history of thrombosis, the lowest risk device to insert is a subcutaneous port. For patients that you know are going to have chronic illness, multiple hospitalizations, administration of intravenous medications, they should have a port, not a PICC. We know PICCs are easy. It's easy to call you and say, please put it in. But that may not be the best for the patient. And so we have to think about those types of issues in trying to avoid these problems. So recognize that there are contraindications. Contraindications to PICCs and even midlines for patients who have a history of thrombosis. Ultrasound allows us to do better assessment and understand the types of veins that we should insert. We now have good instruction on tunneling PICC lines. That is, using the whole needle to go up to a larger vessel access. That your insertion of your needle may be in the mid-upper arm, but that's not where you access the vein. You go subcutaneous and go higher and access the vein where it's larger. Those are some methods that help us to reduce the risk of thrombosis, and that information is now fairly widely published on those procedures and those practices. And then we need to look closely at patients' risk factors and make sure that we avoid certain patients for certain types of devices like PICC lines. So what does the future hold? Well, we need to have ongoing investigation into these problems. We need more research and publications to give us direction on what our practice should be. We need all of you to contribute. What are you doing for your specialty?